will be 10 minutes late. So Dr. Krunal will be joined us in 10 minutes time. So to start with, ladies and gentlemen, distinguished colleagues and honored guests, and Professor Adabisola, CEO of TORG, welcome to Pan Asian Congress. So it is my pleasure and privilege to open this important session. My name is Assistant Professor Damaka. I'm Education and Training Director of TORG. So this is presentation focused on surgical safety, quality improvement, and future of orthopedic surgery. We are joined by researchers, educators, and innovators from across the globe, united by the same mission, or just the aim is just to enhance patient safety, elevate standard of surgical quality, and shape the trajectory of orthopedic care through the meaningful dialogue, scientific rigor, and collaborative innovation. So, as Director of Education and Training Program, I am deeply proud to see this platform bring such a distinguished experts and leaders across the globe with different insights to share the pressing challenges facing our field. We also eliminate opportunities and breakthroughs that are redefining modern orthopedic practice. We appreciate your commitment, time, and your dedication to improve orthopedic care across Asia and beyond the continent. With that, it is my pleasure to officially open today's session. And now I call upon Dr. Isahan, Director of Quality and Performance Monitoring of TORG, to deliver an opening remark on today's session. So the floor is open for Dr. Isahan. Please welcome Dr. Isahan.
Thank you so much, Professor, for your kind words. So, good morning, good afternoon, and good evening to all our distinguished delegates joining us across the world today. On behalf of TORG-India, it is my pleasure to welcome you to this landmark Pan Asian Congress. We are really honored to host participants from across 22 countries today, including Ireland, India, the United States, Rwanda, Ethiopia, Tanzania, Nigeria, the Democratic Republic of Congo, Ghana, Cameroon, Mauritius, Pakistan, the Philippines, Somaliland, Zambia, the UK, Qatar, Kenya, Namibia, Indonesia, Australia, and more. Your presence reflects a truly global spirit of this conference and a collective dedication of advancing safe surgery worldwide. My name is Dr. Ishan Bakshi, Director of Quality and Performance Monitoring at TOG, and it is an honor to serve as your co-chair for this important scientific gathering. This Congress stands as a testament to TORG's core values, that is collaboration, education, equity, and continuous improvement in surgical care. By bringing together surgeons, educators, allied health professionals, researchers, and global surgery advocates, we reaffirm a shared belief that safe surgery is a universal right and that the education can be transcended across borders. Throughout today's session, you will hear from distinguished leaders in orthopedics, sterile processing, and global surgery, experts who have shaped practice standards, influenced policy, and continue to drive innovation across diverse health systems. Their insights will help us reflect, refine our approaches, and envision the future of orthopedic care with both clarity and purpose. We extend a sincere appreciation to each participant, institution, and partner joining us today. Your encouragement standards our global commitment to improving operative room safety and surgical outcomes across the regions. Thank you once again for being here, for contributing to this important dialogue. So, without further ado, I would like to introduce our first speaker, Dr. Gratien Nzayikorera. So, Dr. Gratien is a respected orthopedic, trauma, and arthroscopic surgeon whose work spans clinical practice, academic leadership, and research mentorship throughout Africa. Holding an MCH in orthopedic surgery, he established himself as a key figure in advancing modern surgical approaches and training within the region. Dr. Gratien serves as a lecturer at the University of Global Health Equity, where he guides curriculum development, academic delivery, and multidisciplinary research initiatives. He is also a lecturer. He's all. He is also a lecturer at the University of Rwanda, a role through which he trains the next generation of surgeons and allied health professionals, integrating evidence-based practice with surgical skills. His commitment to global surgical advancements extends to his role as a global research mentor with the TORG. Through this platform, he supports multi country research, facilitates capacity building, and it contributes to improving perioperative systems and outcomes across diverse healthcare settings. In today's Congress, Dr. Gratien will be speaking on the future of orthopedic surgery, challenges, opportunities, and innovations. His presentation will explore evolving trends, technological shifts, and the strategic priorities needed to strengthen orthopedic care in both low resource and high resource environments. I would now like to request Dr. Gratien to take the stage. Welcome, sir. Thank you.
Thank you so much, Prof. Ishan. Thank you for the good presentation. As you said, I'm Dr. Gratien Nzayikorera from Rwanda. I'm orthopedic surgeon and arthroscopic surgeon. And also, since I'm in the teaching hospital, I also contribute in teaching in surgery and anatomy in both universities, University of Global Health Equity and University of Rwanda. And I like research and I contribute a lot in research in both universities. So not taking long, I think I can share the slide and we go through. Are you seeing the slides?
Yes, please.
Okay. So we are going to talk about the future of orthopedic surgery. We have challenges, opportunities in innovation in global context. This is the global overview. Where orthopedic disorders rank among the leading cause of the disability globally. The swift increases in the aging of our population, which lead to the growth prevalence of those weak bones and also traumatic conditions. So there is unequal global access to advanced surgical treatment. In some centers or some countries, there is even nothing. They just improvise to see if they can help their population. There is necessity for the scalable innovation. So, as we can see, the epidemiology, we have globally 1.7 billion individuals and are affected by these trauma and other musculoskeletal disorders. So trauma is responsible for approximate almost 10% worldwide mortality. So you can see the percentage is high. So that's why we have to take care and know how to approach and give care to our population. The prevalence of hip and knee osteoarthritis is also projecting high. It will be doubled when we reach in 2050. So major demand shift in Asia, Africa due to the demographic and urbanization. So the key challenges we have, especially in the low and middle income countries like our Africa and Asia, we have the workforce shortage, we have limited access to the good investigations and implants. We have also some trainings which are not standard and which are also lacking. So we have raising of costs and reimbursement pressure. So like the treatment is high and is expensive. And we have also that pressure of reimbursement. So in workforce and training gaps, we have severe shortage of orthopedic surgeon, especially in low and middle income countries. And there are elevated patient to surgeon ratio. So the surgeons are few and the patient are many. So this is overloading the few surgeons we have, and this causes a lot of problem and cause of a lot of errors when the surgeon is overwhelmed and is tired. Sometimes he can make mistake. He can also not attend all the patients, and you find the patients now are heading to the complications. So trained surgeons are migrating to the high income nations, and you find those low income countries or middle income countries, they are still having that issue. They are training their people, but them also, they want where there is good money and there is good life. So they have to migrate and go to the good countries. So there is necessity for training that is based on competence and supported by simulation. So we need to have some training centers in our areas which should produce enough surgeon to help our population. Otherwise, we are producing less, and also they are also migrating to where they can get a good salary. So the challenge in technology, we have limited access to those sophisticated investigation like MRI, 3D, CT, or printing, navigation system in resource constraint and environment. So from there, you find someone just using only X-ray and is going for surgery. But this, it's a big challenge because there's a time a surgeon needs these sophisticated investigations to be done before heading to the operation, or to help the surgeon to see if he can take a good get a good diagnosis and take a decision. But we still lack that, and we just take decision using only X-ray, or you just use physical examination and you suspect, and later on you send the patient after suspecting the diagnosis. We have significant capital and maintenance expenses. So capital is low and maintenance of what we have, it is also down. So we need enough support. We need support from the government. We need support from maybe abroad so that we can maintain what we have. And also we have insufficient supply chain for implant. For example, in my country, like to get an implant for shoulder replacement, it's hard. So you see, we have some insufficiency in supplies, and also getting total hypototomy is very costly. So you find some patient, we are just removing the head and we just do gallstone and we leave the patient on traction for short time and the patient adapt, which is not needed, which is not enough. We need to get those implants and see if we can help our population. We have also the aging population, which is increasing the number of osteoporotic fractures. And also we have also complex comorbidities in those old ages. And you find because of the comorbidities and the fragility of the bones, old people are getting more complicated fractures. So need for orthogeriatric care models. So we need also to be trained in this orthogeriatric. We need also how to know this, to have skills and also some supply to help us to see if we can take care of our old people. We have strain on surgical volume and the system capacity, as I said before. We have a high volume and system capacity is low, and also the surgeons are few. So from there we get many challenges in helping our population. We also have a trauma burden where the accident road traffic injuries are high in Africa and Asia due to our population who are using the motorcycles and using the cars but on high speed, and they are not well controlled. So from there, and we have bad roads, you find we are getting many accidents and many patients with trauma comes to the hospital. There are limited trauma network and emergency system in place. Like, for example, you might find orthopedic or the trauma centers in our countries are few, are limited, or they are far from where the accident are happening. And you find also we have the referral system, which is complicated or sophisticated, where you find a patient reaches where the trauma center is after a long time, and you find the patient has come maybe after 3 weeks when the bone is uniting, or you find there is too much colors and you have to enter and start now using much time, too much bleeding, and you see which is not nice. What some time you needed to fix the bone without opening, and later on, since there is colors, there is no way you can do it without breaking that colors, and you end up opening the patient and bleeds. So these are all the complications, the challenges we get to the trauma. As we said down, there is also delay receiving care due to our referral system and having few centers for the trauma. So you find a patient reaching late with long-term complications. So the opportunities we have digital transformation where the AI is coming in to support in diagnosis of the patient, helping us in diagnosis, predictive analysis for implant failure and risk assessment. Yeah, there are some machines which can predict for us or analyze, like shape the implant, and also we get a good implant, or we can even get this machine to help us to predict the failure and the risk which will come later on after operation. We have orthopedic enhance the pre and the post-operative care. We have the blockchain technology for implant traceability. And we have also the robotic and the navigation, which also coming in. In some advanced countries, they already reached there. For us in low middle income countries, we are still below, we are still waiting for them, but we have hope. Maybe later on, maybe in 20 years, we'll be having it. So there is advancement of robotic enhanced accuracy in joint replacement procedure. There is decrease in variability of result. The adoption rate is increasing in Asia in robotic surgery. Next generation system hold the potential for cost saving. So the next generation, we might be having some cost saving. So in 3D printing, here we will benefit, these opportunities benefit the patient-specific implants. You just come and measure and print the implant which is specific to that patient you have. The customer surgical guide, we have local production, which reducing cost in our low and middle income country, and also training model for the resident to help us to train our resident, our future doctors, to see if they can do better and do what is now updated. And we have also regenerative medicine, where the stem cell therapy for cartilage and bone, which is coming in also, and will help us a lot, especially in those old age or in those cartilage loss in joints. So we have gene therapy, which is aimed at osteogenesis and tendon repair. We have imaging, application of bioprinting. We have possibility to postpone the necessity for surgery. And also we have something which is coming in, and I think it is taking everywhere, the minimum invasive technique, where we use a small incision to help our surgeries. This reduces the duration of the hospital admissions, decreases the discomfort and expenditure rehabilitation, advancement in arthroscopy for the joint and the spinal procedures, expanding the role in sport and degenerative condition. So here it will be reducing the hospital stay for the patient because of that. It is minimal incision, and also it will help a patient a lot in reducing the pain and also much time to expend in rehabilitation. And another thing which is coming in is small implants, a smart implant, like devices for monitoring load and healing condition, technology for detecting infection, integration with the patient application, and also customize the care pathway. So here, this is smart implant, which will be also reducing those complications we like facing in this era. So the global innovation model, especially like in India, we have high volume, low cost arthroplasty centers. Especially Africa like to go to India because that is where there is low cost and they have advanced technology, especially in the joint replacements. Like in China also we have rapid adaptation in robotics. In Rwanda and East Africa, development of telemedicine and the surgical ecosystem. So we are trying here in our country and the neighboring East Africa countries to use the telemedicine so that we can attend those patients who are in the villages who can't manage to come and reach safely and earlier to the urban centers. We also help the doctors who are not well trained or those who are not trauma doctors to help those patients with trauma cases. So in Europe, there is value-based orthopedic care model also. So health system transformation, we have integrated trauma network, enhancing supply chain, multidisciplinary orthogeriatric and rehabilitation care, digitalized patient pathways. So about the research and data opportunities, we need big data registries so that they can help our doctors and us to make some researches, and those researches, that's where we get advocacy, and that's where we know what is going on in our areas. We have global orthopedic surveillance system, AI enabled implant life cycle monitoring. So we need also to monitor the implant. We have to know the complication earlier so that we intervene on time. There is a precision orthopedic based on genetic and biomechanical profile. So we also have equity and capacity building in training partnership with other countries which are well developed, like in the north, south, and south. And there is cost-effective implant initiative, although it's high in this in our countries, in the low and middle income countries. We have also developing simulation center and digital skills lab where we can now share everything so that we can see that every doctor is well trained and has some skills which is enough to approach our patient. There's also task sharing for basic orthopedic procedures. So what is our future? What success look like? We have human-machine collaboration in surgery, especially you can see now the robotic is coming in. So we need to collaborate with those robotic to see if we can get success in our surgeries. Regenerative fast approach, smart implant as standard of the care, and global equity in access to orthopedic innovation. So we don't need some countries to lag behind or in innovation. We need all to get equal access to the updated orthopedic and all the innovation which are coming in. Every country, every surgeon need to be trained so that we can help our population equally. So as conclusion, orthopedic is entering in transformative era. Innovation is rapidly accelerating, but it is unevenly distributed. But later on, we might catch up. You find also those low middle income countries also getting good innovation and on time. There's a collaboration, digital technology, training focused on equity, and regenerative medicine will define the upcoming decades. So the future is precise, personalized, minimally invasive, and globally connected. So thank you. These are the references we used. If there is any question, the floor is yours.
Okay, thank you, Doctor. We will have 30 minutes for question and answer at the end of both sessions. So
Okay.
we will continue to the second session. The second session speaker will be Dr. Krunal Soni. He is highly accomplished orthopedic and trauma surgeon whose career reflects excellence in clinical practice, advanced surgical technique, and professional leadership. He holds an MCH in orthopedic and has completed multiple prestigious international fellowships, including FIAS, FASH, and all the others. The credentials that highlight its commitment to continuous learning and mastery across subspecialty domains. With advanced expertise in arthroscopy and shoulder surgery, Dr. Soni has built a reputation for precision, innovation, and patient-centered approach to musculoskeletal care. He serves as the National Director of Operating Room Global India chapter, where he contributes to strengthen surgical standard, perioperative education, and global collaboration. Dr. Soni currently leads the Apollo Restore program and heads Unit 2 Orthopedic Trauma, Arthroscopy, and Shoulder Surgery at Apollo Hospitals. He is also director of the Bombay surgeons in Ahmedabad, a role that reflects his influence in shaping orthopedic service and mentoring emerging surgeons. Today, he brings excellence, clinical experience, academic insight, and strong commitment to quality improvement as he presents on surgical asepsis, foundation of infection prevention in the operating room. His session reinforces the essential role of aseptic practice in safeguarding patient outcome and strengthens perioperative system worldwide. So please welcome Dr. Soni, and I'm happy for joining. And the floor is for you. You can start, please. Thank you.
Hello, everyone. Are you able to hear me and the video is fine?
Sure, yeah.
Yes. So quickly, I will share my screen. My screen is visible, right?
Yes.
Perfect. So thank you for the introduction, and At the outset, I would like to thank the Operating Room Global and the entire organization team who has made a lot of efforts to put this meeting together, and so that we can share our views, we can share good practices with the entire world. I understand that more than 22 or 25 countries and more than 50 participants are right now with us, so that is good. With that, I will start my talk, what I want to share with you. Firstly, I would like to mention that the Indian chapter uh, is doing extremely well in last 1.5 months. My entire screen is visible, or how is it? Can somebody give me an input? You can see entire screen?
Yes, sir, it's visible.
It's visible, right?
Yeah.
So in last 2 months, we could conduct 3 workshops. We have had phenomenal response in these workshops. These workshops were primarily focusing on learning and maintaining surgical asepsis, especially the operating room part. And uh, we trained more than 200 to 250 of our staff, who included nursing officers, healthcare professionals, medical officers, and doctors. And the response has been good, and we have got more and more requests for such workshops. This was all in presence, in person workshops. From here, where are we looking at? So we have formed a new committee, and we are in way of giving a structural organization and responsibilities to our key members. We want to increase the Indian chapter and, of course, the global chapter membership when it comes to the Operating Room Global. We are in process of forming social media pages, especially for the Indian chapter. Also, with the professor, we are planning an in-person Asian meet, and we will involve all the societies, all the chapters for the same. We are in talk of extending fellowship opportunities for international surgeons to come to observe, to have some hands-on experience, so that they get trained well in orthopedic surgery specifically. And of course, we are open to global collaborations to improve system. For example, Dr. Gratien right now talked about few challenges. So definitely we can speak and we can see how we can help each other being a part of a global society. So with this, I'll start with my talk for today, which is primarily focused on maintaining surgical asepsis. Now, when I talk about surgical asepsis, it is basically a set of practice that helps to eliminate and to prevent the growth of organisms, especially in the OT environment. So if I have to put in one word, we can say that this is like a clean, contamination-free surgical area. That is what surgical asepsis is all about. Now, the question is, why do we need to have so much of surgical asepsis, strict protocols, so much of education behind it, so much of training behind it? I'm sure all of us who are in this forum today would have experienced, would have seen, or some of our relatives would have faced some issues related to surgical site asepsis. And especially any individual after some injury, this injuries can be an orthopedic injuries, can be related to GI injuries, and they get surgeries done. And if things don't go as planned, they land up with surgical site infections. So when they land up with surgical site infections, the entire aura, the entire environment for them, for their life changes completely. We know that the treatment extends for a longer duration with antibiotics, with maybe needing for debridement. And at the end of the day, the quality of life for that individual, for that family completely changes. And this is something which we can work on to decrease the numbers, to prevent such episodes from happening. And that is exactly the reason why we all are here today. As healthcare professionals, as nursing officers, as doctors, as surgeons, our main motto, our main aim is to protect our patients. That is the oath which we all take on our day one, and we should always stand by that oath, and we should do everything in our domain to make sure that that promise has been kept. And that's why we've come up with, which is called as Protect Orthopedics program. So this is pertaining to orthopedics, but the principles can be applied to all the surgical specialties, which includes first and foremost prevention of infection at every cost, at all cost. No matter what happens, we keep on doing things so that we achieve this goal of preventing infections, specifically the surgical site infections. Rapid and accurate diagnosis if there is an episode of infection. We want to optimize and be aggressive when it comes to surgical and medical care of infections. Timely treatment is extremely important when it comes to infection, because we know, as per the evidence and data, that infections, once they settle in the body, there is a lot of biofilm formation, and then it becomes difficult to eradicate it. So timely intervention is a key step to prevent and to treat infections. Education and continuous training till we achieve the penultimate goal of zero infections. So this is why we are here. And for today's forum, our main focus would be on prevention of infections, education, continuous training, so that we all can achieve a common goal of zero infections. There is a very good saying in our textbooks which is mentioned, and I've taken the quote, that you can spit in the abdomen, but you don't even dare to breathe near a bone. Now, this is a very powerful saying which is mentioned in our textbooks, and there is a scientific reason behind this. The reason being that any area, or let it be arm, let it be forearm, let it be legs, the bones are usually the deepest compartment of that area. And once if infection settles in that compartment, there is a lot of biofilm formation that protects these bacteria to be fought with the normal WBCs. And that is why orthopedic infections are difficult to eradicate, difficult to treat, take a long duration. And this saying, I can now relate it, that you should not even dare to breathe near a bone. And that is the prime reason for it. We all agree and we all know that our hands, they are the greatest gift of God, and they're the most beautiful creature, most beautiful creation created by God. But at the same time, if we have, for example, today, this is my hand, and if I have to put this hand in a culture dish and grow the bacteria, can anyone guess what is the average bacterial load of our hands? Our viewers, some of them can just, ping and unmute themselves and be talk on this point. Do you think it is around 500 to 1,000 bacterial load? Do you think it is more than 10,000? Do you think it is more than 50,000, or you think it is in millions? Yes, anyone can volunteer and take a guess. So if I change the picture to this, does this give a picture that what would be bacterial load when we culture our hands?
In millions, sir?
Yes, that's true. Average bacterial load of hands, they are uncountable. They are in millions. So although our hands, they are the best creature, they are one of the dirtiest areas of our body, and that's why we stress so much on surgical asepsis. When it comes to operating room and when it comes to surgery, the most important step to eliminate or to decrease this bacterial load of our hands is scrubbing. And I'm going to spend some time, I'm going to share a video so that we learn proper technique of how to scrub before surgery. Okay, so I'm going to share a video and let me know if it was proud. Make sure. So I'll talk as you can see this video. So make sure that you remove all your jewelry. Am I audible?
Yes, sir.
Am I audible?
Yes, sir, you are audible.
Yes, sir. You are very audible, sir.
Yes. So the principle of scrubbing is that we will decrease the normal bacterial load of our hands. It is a time-dependent procedure. That means that when you're scrubbing in before surgery, specifically for the first time of the day, you should spend at least 5 minutes in this process. It is a time-dependent process. Usually the way you should scrub is you should start scrubbing from the fingers and you should go proximal. So you should go towards your forearm, you should go towards your elbow, and you should go towards your hand. That is the right technique of scrubbing. We can use what is available. We can use chlorhexidine or betadine. These are two very commonly available scrubbing agents in all our wards. Both of them are fine. Both of them are acceptable. So as I discussed before, it is a time-dependent procedure and there are 7 steps to scrubbing. Each step you make sure that you do at least 20 times. 20 times is the key, that it is a time-dependent procedure. So you start from palm to dorsum 20 times, palm to dorsum in other hand, palm to palm 20 times, interlocking of fingers 20 times. Make sure you scrub your thumb. So right thumb in left and left thumb in right 20 times. Next is to scrub your fingertips in one of the palm. So right fingertips in left palm and left fingertips in right palm. And then last step is to scrub your wrist and go proximal. The important message here is once you have done scrubbing of your hands, make sure you go up and don't come down, because this has become a relatively good area where you have eliminated all the bacteria or you have decreased the bacterial load. So you don't come up again, you always go proximal. Now, as I said, once you're done with scrubbing, next is to rinse all chlorhexidine or betadine. And the way we do it is same, that you rinse your palms first, you rinse your wrist, you rinse your forearm, and don't do it in reverse way. Make sure your hands, they remain up all the times. All the times. And during this process, if inadvertently you touch anywhere, the entire cycle repeats. The entire cycle starts from scratch. It starts from zero. So this is extremely, extremely important in decreasing the bacterial load of your palms, of your forearms, of your elbows. As I mentioned, if you're scrubbing in for the first time during the day, you do this 3 times. So the very first time you do it till your arms, the second time you do it till your forearms, and the third time you just scrub your hands. So there are 3 cycles, especially if you're doing this for the first time during the day. Right thumb in left hand. Everyone is okay? Everyone is understanding? Is it clearly visible, audible? Fingers to the palm.
Yes, sir.
Yes,
Yes.
sir.
Okay. So this is the most important part when it comes to good OR practices, good OR etiquettes, good scrubbing, time-dependent procedure. As I mentioned, there are 3 scrub cycles, specifically if you're scrubbing in for the first time during the day. The first is you scrub your hands, arms, and extend it to 2 inches above the elbow. The second cycle is hands and halfway till your forearms. And the third cycle is only hands. You are supposed to do this at least 3 times for the first time you're scrubbing in. So even after doing a good 5-minute time dependent procedure, studies have shown that there are few areas of your hand which are missed during scrubbing. And this particular slide is to highlight those areas so that next time when you're going in for scrubbing, you make sure that you remember this slide and you make sure to scrub these areas well. So the areas which are visible in red, they are the ones who are easily missed, which includes the tips of your fingers, the web spaces, and your thumb. So make a note of it. Make sure that next time you're scrubbing in for your cases, these 3 areas are never missed. Second important thing is gloving. As we all know that we can only decrease the bacterial load. We cannot sterilize our hands. We cannot do that. So to help our patients get good OR practices, we do something which is called as gloving. Now, in the operating room, we follow something which is called as no touch technique when it comes to wearing gloves, specifically for the surgeon who's operating. I have a small video for this and I will play that and I will talk to you while it is being played. As you can see, one of our staff is trying to help the surgeon wear a glove wherein he opens the entire glove, makes sure that he's opening it wide enough for the surgeon to just insert his hand within the glove and not touch the glove. This is called as no touch technique of gloving. Extremely important when it comes to maintaining and decreasing your bacterial loads. Once again, we'll see the same thing. The scrub staff can open the gloves and let the surgeon wear it without the surgeon actually touching any glove. So this is the no touch technique of gloving. We have to follow this. This is a standard of care when it comes to good OR practices. Third important thing is to differentiate in a OR setup what is sterile and what is non-sterile field. For all practical purposes, for all surgical fields, it can be orthopedic surgery, it can be GI surgery, it can be a head neck cancer surgery. The field which is paint and draped and at the level of the table is all sterile, and the field which is below the table and not draped well, that is all non-sterile. So if I have to give a blanket rule, everything above the level of the table and the area which is near you and draped well is all sterile and all rest of the area is non-sterile. And we have to make sure that we always separate the non-sterile and sterile areas. We don't mix and match. We always stay in sterile zone. Our hands are always in the sterile zone and we don't touch anything which is not sterile or we don't know if it is sterile or not. Right? This is pertaining to the OR field. When it comes to we as surgeons or healthcare professionals or the scrub staff, when we have scrubbed in, the area which is close to your chest, the area of your forearms and hands, the green area, if everyone can see, this is all considered as a sterile zone, and rest all the areas for all practical purposes, we consider it as non-sterile and we never try to touch it. Is this clear? Is everyone following? Anyone can give me a thumbs up?
Yes, sir.
Yes.
Yes, it is clear.
Yes. So there are some do's and don'ts which you have to follow when it comes to operating room. As I mentioned, make sure that you're always standing in the sterile field and your staff who's not scrubbed in, they're always away from the field and you are in the sterile field. Make sure that the hands are always above the level of waist where it is visible and you don't lower your hands or you don't insert your hands in the axilla or over the back, because as we discussed, these are all non-sterile areas. So we don't want to mix and match the sterile and the non-sterile zones. And at times in OR with surgeons and with assistants, we change positions. We have to change positions with the surgeons also. We have to change position with our staff also. So what we do is, the way we cross each other is, either you face front to front while crossing so that you maintain sterile zone with the sterile zone, or you cross back to back so that your non-sterile zone is facing the opposite person's non-sterile zone. And this is the right way, and this is the correct way to cross in a OR when you are scrubbed, your assistants are scrubbed, your healthcare professionals are scrubbed, or nursing staff is scrubbed. Extremely, extremely important. There are some things which you should always avoid, as I discussed it before, that if in surgeries at times, the surgeon, the primary surgeon or the assistant surgeon would have few steps wherein he's not required and he has no work to do. So at that time, it is important that the hands, he or she does not lower it, or he or she does not put it in the axilla or on the back. This is incorrect. This is also incorrect. You should never fold your hands, especially if you are scrubbed. So this is incorrect. This is incorrect. This is the right way to place your hands on a table where the surgeon can see, where everyone can see, and you can maintain sterility. So our main and penultimate aim is to achieve zero infections. We keep on training so that at the end we are able to achieve a common goal of achieving zero infections, and our patients get benefited, they get good outcomes of our surgeries. So always I'm up for training people. I'm always there to advance surgical education. This is first of many series which we will initiate, we'll collaborate, and we'll keep on doing this till we achieve our goals. And this is the talk on surgical asepsis which I wanted to give. This is a basic talk, it is a primary talk, and we'll build on from here. So in orthopedic surgery, I truly believe in this principle that orthopedic surgery at its core, it is like a biological garden. When we respect tissues, when we preserve blood supplies, and when we give right condition, the bone grows and it flourishes. This principle can be applied, I guess, to all other surgical specialties, that if we do good OR practices, if we maintain sterility principles, we will give good outcomes to our patients. So with this, I conclude my talk. I'm happy to take any questions from our viewers. I am happy to discuss something again if somebody has a query.
Thank you so much, Dr. Soni, for such a lovely session. I hope and I'm sure that the viewers really learned something from your well-structured, informative talk. I would now like to keep the floor open for any questions from our audience. Please feel free to unmute yourselves and put up the questions, or you can put up the questions in a chat box, and we and our speakers will be really happy and appreciate your questions, and we'll be happy to help you out. Thank you.
Yes, somebody has raised hand. Can you unmute them and let them speak?
Okay, shall I proceed?
Yes, you can.
Okay, thank you very much. Thank you for the insightful presentation. I'm Neguse from Ethiopia, Ethiopian chapter TORG member. Just your presentation really determining. It is appreciable. Thank you, especially your presentation focused on infection prevention practice to reduce surgical mortality regarding infection, which is very important. I have one question. My question is, as you said, infection prevention is a key practice, or it is a method. It is a simple and doable, especially for resource limited areas. And hand hygiene scrubbing is a very important practice to reduce surgical site infection. But the whole infection prevention practice can be addressed, or the impact of the infection prevention practice can be addressed through surveillance. One of the surveillance is surgical site infection surveillance. What is your real practice, or what is your real data, or what is outcome of your infection prevention practice? If so, if you did before, or if you did the active or active surveillance, especially on surgical site infection, because it is the impact of the infection prevention is one of the impact of infection prevention is surgical site infection reduction. What data do you have?
So I'll start with what is the global data. The global data is the average of global surgical site infection is around 3 to 8% of all surgical specialties. We have reviewed our data of last 5 years, and our rates of surgical site infection is 1.3 to 1.4%.
Okay. Did you do the active surveillance of surgical site infection?
So we have a norm, and we have a follow-up at 3 months. We have follow-up at 6 months. We have follow-up at 12 months, 2 years, and 5 years. We reach out to all our patients who have had surgeries, and we collect data from them. And as per our data, the last month we finished collecting all the data of 5 years, and our 5-year infection rate was around 1.35%, if I have to be precise.
Thank you very much. Thank you.
Yes.
So I think we have a question in the chat box.
Okay,
If
we'll
you see.
be happy to answer it. Can you read out that question?
Sir, Mohammed Muzabuddin is asking for the practical approaches to sterile field management.
So, practical approaches to sterile field management. As we discussed, key part here would be to make sure that we zone out the sterile zones from the non-sterile zones, and never to mix and match these two zones. And that is one of the talks which I will be taking in the coming sessions. So since this was an introductory session, we stick to basic principles of OR. And once we keep on doing this, I will be sharing a lot of more details and advanced knowledge, how to do it, what to do it, what not to do it on a much detailed level. So we will definitely answer you next time when we are meeting, because that is an extensive talk. For today's forum, we have limited it to basic surgical asepsis.
Thank you, sir. We have a question from Ali Guo. I request them to please unmute themselves and continue the question.
Yes.
Good evening, everyone. Good evening, Deb. Good evening, presenter. Thank you for your wonderful presentation. It was a clear presentation and very educative. Now, my question is this. In surgical site infection, do we involve the patient or not? Because with my years of experience in theater and experience surgical patients from different hospitals and in my own hospital, I find out that we don't usually incorporate the patient into the surgical site infection prevention, in the sense that sometimes we think about surgical site infection is coming from maybe the surgeon, the scrub nurse, all the surgical team members. But we forgot to see that at the end of surgery, sometimes most patients after surgery, when they recover from anesthesia, some of them will pull their incision area plaster, whatever plaster you have used, whether whether Premap or whatever you have used to close the incision after this thing. You see them pulling it out to see how the incision line is, to see how the surgery went and all whatnot. With even their dirty hands, they have not even washed. Sometimes you find out that that patient is being the patient is infected. When you open the wound, you find some greenish coloration along that area, and you'll be asking yourself, where does this one come from? Is it from the surgery we have done or not? It only takes nurses or doctors who are very observant to find out that, oh, this plaster has been losing. Who lose it? That is when the patient will not tell you, okay, I tried to open it to see what was done. So I'm like, what do we do in this case? Are we not supposed to incorporate our patient into surgical site infection during outpatient department or at a surgery department? Let's say the patient is coming for surgery. It is the responsibility of the surgeon to let the patient know what is involved, both in sterility and all whatnot. It is also the responsibility of the surgical nurses in the ward where the patient stays before coming to surgery to also educate that patient that after surgery, you don't touch your incision area, you don't remove the plaster unless when the surgeon says it. So thank you.
So that's a very good topic and very good question. When we are practicing a surgical site infection prevention program, we have something which is called as patient education. And we always counsel, communicate with our patients that this is the pre-surgical things which you're supposed to do. This is the peri-surgical instructions, and these are the post-surgical instructions. We communicate well, we have a very transparent practice, and we make sure that the patient understands this and agrees to this. Because as for preventing surgical site infection, it involves a team approach, and the patient is very well the part of our team. So patient education is a very key factor when we want this program to run, and we make sure that we communicate with our patients, their family members, that these are the instructions which you're supposed to follow, these are the don'ts which you're supposed to follow. So an easy way is to give them handouts. Most surgeries can be little bit planned. So for example, except for the super emergency cases where we really don't have that time to communicate, most of the cases we'll be able to communicate with our patients and give them some printed handouts that these are the don'ts and these are the do's which you should do, which we usually do with all our patients, and most of them are able to follow it once they are communicated well.
Thank you, sir. I hope Ms. Aligio, sir, answered your question well. Moving on, we have Mr. Yeah, thank you. Moving on, we have Mr. Jonathan. Sir, please, you can unmute yourself and continue with the question.
Hello.
Yes, thank you. Thank you very much, Dr. Soni, for the presentation, which is very insightful and very helpful for people working in the operating theater. I myself am from Mauritius, and I'm working currently in the OR for almost 10 years. I saw the saying you mentioned, you can spit in an abdomen, but you dare not breathe near a bone. And I believe this is very important. Coming back to that, I would like to understand your views on mask wearing during surgeries. Where do you stand on that? Thank you.
So I'll come back to that saying. So that was more of a philosophical saying that you can get away with spitting in the abdomen, but that does not mean that I advocate doing it. It is just a saying that abdomen area is more forgiving when it comes to infections, and bones, they are little less forgiving, and that's what the message was when I put that quote. And with respect to masks, of course, I am an extremely strong and strict believer of wearing mask, wearing caps, scrubbing into your OR scrubs each time you go in the theater, and if you come out, you have to change. but this is something which is extremely basic. So I presume that all our viewers would definitely know these basic things, and that is the reason I did not specifically include. But since you have mentioned this, I will go on record and say that extremely important to wear masks, extremely important to wear your caps, extremely important to change into your OT scrubs, extremely important to remove everything in your hands when you're going in for surgery. No bands, no threads, no rings, no jewelry whatsoever, nothing, nothing. Extremely important to remove your inner wears, your clothes, and change it into your over a scrub. So yes, that absolutely yes.
Thank you. Thank you for the insight.
Thank you, sir. And I would like to tell our audience that Dr. Gratien is also available to answer a few questions if somebody has a few questions from the first presentation. Okay, moving on, we have another question, sir, from Muzebuddin or itself. He's asking the types of gloving techniques available.
So as we discussed, and I've shown you the first technique wherein it is a no touch technique, wherein one of the scrub staff who is already scrubbed in helps the surgeon to wear that glove. So this is the standard of care when it comes to surgeons wearing gloves. No surgeon should ever wear gloves on their own. They should always follow no touch technique. Now, when it comes to the nursing staff or the scrub staff who have already scrubbed in, I have a separate video of it. I wanted to discuss it, but since we did not have time, we are short of time, I did not show it to you. We'll make sure to include that video next time when we are meeting. So, Ishan, if you can put a note of this, I'll definitely share a video technique that how the scrub staff or how the nursing staff they are supposed to wear the gloves.
Will do, sir.
Okay.
Hello.
Yes,
Yes.
sir, please continue.
Go ahead.
Okay, good evening from this side. Thank you very much, Dr. Soni, for the presentation. I also want to add the note of on the implementation of surgical site infection prevention bundle, SSI bundle, which also include skin preparation. Skin preparation start from observation of the skin. If there is any infective lesion existing on the skin, it's better not to go on with the surgery until the infective lesion is taken care of. Glycemic control and the temperature control also, especially for some age group and in surgery that is lasting more than 1 hour, are also important aspect of surgical site prevention. And as you mentioned, as another participant mentioned earlier, the patient education also is crucial to prevent surgical site infection. Thank you very much.
So to answer you and to extend what you're talking, definitely if there is an infective lesion around the planned surgical site area, and if the planned surgery is an elective one, we would like to wait for some time, let the lesion get treated properly, and then move on to our elective surgeries. Yes, glycemic control is extremely important, and especially in all our elective patients, we do fasting blood sugars, we do postprandial sugars, we see their glycemic control, and if required, we involve a physician to treat them before we take up for surgeries. So this is a part of our pre-surgical workup, and we strictly follow it for all our elective surgeries. We understand that in emergency surgeries, this may have to be accepted the way it is, but all elective procedures, we are very strict when it comes to pre-surgical planning, intra-surgical and post-surgical. Yeah.
Thank you, sir. Next we have is Miss Gloria. She's asking, how do you ensure that scrubbing is proper? As some of OR teams don't follow scrubbing steps, do you have any way to make sure that scrubbing steps are well done?
So, Gloria, when it comes to following good practices, and we do not actually have any markers or indicators which we can test physically, but as a part of our team, as a part of responsible person who are coming in touch with the patient, who are being a part of our team, I guess we have to train and we have to trust them enough so that they are aligned with us and they are aligned with our mission. But if I have to answer your question, there is no way that we can actually test or check whether the scrubbing has been done or not. So I would suggest that we spend a lot of time in training and making them aware that why this is important. So I hope I might have answered your question.
Yes, thank you.
So, next we have Mr. Amuel. I would like to request Mr. Amuel to kindly unmute themselves and continue with the question.
Hello.
Yes. Hello. Hi.
Good evening from
Good evening.
my side. I'm from Sierra Leone, the eastern part of Sierra Leone, West Africa. I'm sorry that I was late to join this meeting because I was driving afar to come to my hospital. But a little part I was able to catch up. The presentations is very interesting and is very educative. And with regards to this surgical site infection, one of the contributors was talking about patient presentation. And this is a part of the country where we normally see patients that come to the hospital. For example, they have already have a perforated appendix and they are developed peritonitis and they come to the hospital. So my question is, in this surgical site infection prevention, do we also consider the disease package the patient is presenting? Because most of the time I've seen you can maintain all the sterility within the OR, but after the surgery, like during the first dressing, after like 3 days, you want to change the dressing. I see surgical site infection. The site is already infected and you see pus coming out of the site. So do you also consider this as a factor and the surgical site package? That's my question. Thank you.
So that's a very good point and question. As I discussed, in emergency surgeries, there is very little time for us to have a pre-surgical education and pre-surgical instructions that we can communicate with our patients and the team. But all that being said, all the intraoperative steps, all the intraoperative principles, all the intraoperative etiquettes can be absolutely followed even in emergency cases, and that's what we do. We cater to a lot of trauma patients wherein they come in for after a road traffic accident or injury, and we make sure that our OR practices are absolutely strict and they adhere to all the surgical asepsis principles. So pre-surgical in emergency cases may be able to do, may not be able to do, seeing the patient condition and time. But when it comes to intraoperative practices, they don't change, they never change, they're absolutely the same.
Okay, thank you, sir. I would like to ask Dr. Gratien if he really wants to add anything to the discussion going on. Sir.
Thank you, Dr. Ishan. What I can add on this topic, yeah, the surgical site infection is the major problem we have, especially in our hospitals where we don't have patients who are well educated, or where we improvise, we repeat using the implant, like you find you removing the implant, you're sterilizing it and you're putting it back to the patient. So we face many challenges, even when, as we said, scrubbing, you find a new student entering the theater, maybe he have that little knowledge in scrubbing, or you find the patient is just walking in, you find there is high number of the student in the theater, and that one also causes the infection to the patient. And also our surgery time can also cause infection. Like if you spend more than 2 hours and you don't give again the prophylactic antibiotics, the patient is highly predisposed to the infection. So it's better we take care of the infection control so that we can see if we can achieve or we can prevent those complications. Otherwise, infection is everywhere and it's hard to prevent. So everyone is entitled to prevent. You can't give it to the surgeon or to the nurse in charge of the theater. Still, other people will just come in and you find that person in charge is not around, and you find someone is just sneaking in without those prevention control, and you find is the one carrying the infection. Other thing I've seen, there are some hospitals where you find every 3 months they have to come and check and control. They take samples from all the surgeons and all the nurses, all those theater attendants to see if there is any carrier so that they can prevent it. So thank you.
Very solid and very good point raised by Dr. Gratien that prevention of infection is a collective and a responsible team effort. It is not one person who can achieve this, it is a collective team effort. So, very valid point. Thank you.
Thank you so much, sir, for your valuable insights.
So, I guess we can move on. I will stop sharing my screen, Ishan, and we can move on to the next speaker.
Actually, sir, we don't have any other speaker. But we really have a few more questions if it's okay.
Yeah, absolutely. We are up for questions. Yeah,
Okay.
you can share.
Okay. We have a question from Valence. He says that in Rwanda, some hospitals there are do not have running waters in theaters. So how can they perform proper hand washing regime without water supply?
Now, I understand that this is a challenging problem, but without adequate source and a reliable source of water, it's very difficult to have surgical asepsis and surgical scrubbing done. I am not very sure how I can mitigate this challenge, but if I have to answer the question, since it has come to this forum, I would say that it is extremely difficult without good quality water to have strict adherence of surgical asepsis.
Yeah, as to also help you in answering this question, I'm from Rwanda, I know. Even some private clinics, you find there is no water or their water system is having a problem. But the easiest way is to call the nurse or someone else to hold water and pour for you. Otherwise, it's not easy to scrub and get water by yourself.
That was a really new insight for us, doctor. Okay. Moving on, we have another question from Abel. So he's asking that do you have any experience with the prevalence of surgical site infections in sickle cell patients undergoing arthroplasty?
So, sickle cell patients, their immune system is a little bit on the lower side. So, what we follow for all our arthroplasty patients in sickle cell is to give them pre-surgical antibiotic prophylaxis for 7 to 10 days. We do 2 rounds of investigations with respect to their complete blood counts and the WBC counts. And if their counts are really on the lower side, we again wait for some time and then only plan, because arthroplasty is a planned surgery. It is not an emergency surgery. So if they are not on the threshold, then we wait for them. We don't do surgeries.
Okay. So the last question for the okay. So we have another question from Femi. So she's asking that how can we tackle the culture perspectives with the OR practice perspectives? For example, in some culture, they are not supposed to cut their nails during their menstrual cycle.
So this is challenging because everyone has some personal beliefs, some religious systems with which they are associated, and I understand and I've faced it that it is difficult to mitigate these religious practices. So the easier way and a good way would be that if some person has these religious strong beliefs, then you do not let them come on OR days or during their this time, and that's the best way you can maintain your surgical asepsis. If they cannot change, I guess it is good to give them a break for those days and let them be replaced by somebody else. But you never compromise with the principles.
Okay, sir. Mr. Jonathan really wants to add one thing that to our earlier discussion about absence of water in OR setting. He wants to ask that what about use of alcohol-based gels for hand hygiene in the absence of water?
So if you are advocating use of alcohol-based gels, then the volume which you'll require for one scrubbing is too much. I don't think so. It is resourceful to use that much of alcohol-based gel for one scrubbing. So I doubt if this is reproducible technique. Rather than that, it will be easier for people who are facing this challenge to overcome it with the help of availability of water.
Thank you, sir. Dr. Gratien, if you want to add anything on this, please, sir.
Nothing much to add in. To add on what Dr. Soni said, and it was so nice, and it was well explained about aseptic technique. And sure, it is a crucial things. We suppose all to work on it together so that we can see if we can reduce the septic.
So I guess we close the forum, Dr. Ishan. We have
Yes,
answered
sir.
all the questions. If our viewers have some questions, they can email or message you, and definitely we'll answer everything. This was a good talk, very insightful by Dr. Gratien to share his views. It was very elaborative, and I'm sure that with the operating room global, we can collaborate and we can definitely help each other out. And that is why we are doing what we are doing. Yes.
Thank you so much, Dr. Dr. Soni and Dr. Gratien for their valuable time. I would now like to request Professor Demeki to take the stage for the closing statements. Thank you so much, sir.
Okay, thank you, Dr. Isan. So as we come to close today's session of the Pan Asian Congress, I would like to express my sincere appreciation to all our speakers, participants, and distinguished guests. We had a very insightful and provoking presentation, highlighting essential pillars of surgical safety and quality improvement by both speakers, particularly shaping of the future orthopedic surgery and orthopedic care. So to our esteemed speakers, Dr. Gratien and Dr. Soni, thank you for your expert contribution and ensuring this congruence with your knowledge and expertise to the TORG International. And also I would like to say thank you for my colleague, Dr. Isan, and the entire TORG team. The special thanks goes to our CEO, Professor Adabusola, for giving such a great opportunity for all of us across the globe to discuss such an essential and very crucial topic.
She is just hi.
Yeah, she is here. And most importantly, for our attendees and for your engagement, questions, and commitment for advancing orthopedic care. So thank you once again for joining us, and we look forward to welcome you for future TORG events. And it's time for Professor to speak and to give some acknowledge speech. Thank you once again.
Thank you so much, everyone. It's been very insightful. I've learned a lot, even while in the background. I've picked a lot of things. The speakers actually spoke a lot about the topic. They were well experienced, and I want to say thank you, first of all, for honoring our invitation. Thank you for sharing your knowledge. Thank you so much. And I want to say, first of all, in terms of what the first speaker mentioned, the future of orthopedic surgery, he mentioned the challenges in low and middle income countries. I'm actually aware of that, coming from both backgrounds, and specifically, I would say my passion, even in my dreams, is orthopedic surgery. So I'm very, very passionate about ortho. I know back home in Nigeria, there are challenges as well. So some of the things mentioned is not just in Rwanda, it's across most countries. I would say, orthopedic surgery have advanced a lot. For the navigation systems, yes, I can say we have the navigation systems, even in Ireland. For example, Stryker would use Mako system. I know Depuy Centers, they have another system. Zima, they have the ROSA robots for arthroplasty. The challenge basically would be in terms of funding of those robotic systems. And even if it's not used, hospitals will still have to pay to maintain them. The cost could be in millions. So for example, if we say, oh, we want to have this, if you buy it as an institution and you don't put it into use, it's a huge cost as well for the facility, because that robot needs to be maintained. So it's a challenge. I know hopefully in the next few years, things are going to change for Asia, for Africa, for all low and middle income countries, hopefully positively anyway. And we have a way to facilitate more trainings. I think 2 years ago, we were trying to get in touch with Stryker, especially even to facilitate training sessions, even if they could have hands-on. For example, in Ireland, even not just surgeons, even perioperative nurses as well, they get virtual reality practice on all these robots and navigation. So they have a way of liaising with the companies, having experience even to practice on the robot and do a lot of things, because there is benefit to the conventional systems. It would really help you to map out the joints before time, to select your implants, so not to go into the joint blindly. And even most importantly, soft tissue balancing, you would know when to take up the posterior ligament, cruciate ligament, and when to maintain the ACL and other stuff like that. So it's really, really good. And I hope things are going to change for the best in the next few years. Let's put it that way. So thank you so much, Dr. Gratien. Thank you for sharing your experience. And I want to say thank you to Dr. Soni as well. I'm aware everyone knows about this, that's TORG-India, even though it's one of our most recent chapters. They've been doing a lot in the background, especially with minimal number of teams, let me put it that way, because we don't have the executives set up yet for that chapter, but they've been able to achieve a lot. From the report, I could see that 3 workshops, over 250 professionals already trained with significant achievements and with significant impact. That is outstanding. I want to say well done, and thank you so much for all you do. And as Dr. Soni mentioned, we are looking forward to have observership, because I know his facility is one of the best ones in India. So we are looking forward to have clinical observership in that facility, and even fellowships as well, hands-on fellowships in orthopedic surgery. And hopefully our prayer is going to be answered very soon. So thank you so much for that. In terms of infection prevention and control, you've mentioned a lot. You've demonstrated really well about how to actually do it right. I think we might do another phase of that presentation in the new year, in 2026, hopefully, and expand based on the areas that the questions have touched. So we might actually expand on that. And then I want to say as well, someone mentioned sickle cell. I know what we do in Ireland, for example, when patients have compromised immune systems, or even as routine, they started this vitamin irrigation. I'm not sure that's povidone iodine. I'm not sure if that's in place in India or other countries, but I can guarantee that European countries have started using this because it's evidence-based, proven that vitamin irrigation would help to reduce maybe bacterial load intraoperatively. This means that the povidone iodine would be mixed with the saline irrigation at a percentage. I think it's 10 mils of povidone to 1 liter of saline or sodium chloride. So this is all over the internet. There is research, it's research proven that vitamin irrigation, povidone iodine has been really, really effective, even in prevention of intraoperative infections, and because it's really, really needed. I'm not sure about other fields. I know the only issue is when you have to you have to transfuse the patient's own blood back into the patient, like autologous transfusion, and you do that in the operating room environment. For that, you have to make sure that any blood supply from the patient is not contaminated, not with Vidin, not even with saline, as much as it depends on the procedure and it depends on the evidences around it. So that's one of the things we have to bear in mind. And at the same time, I would like to say thank you to everyone. Thank you to the co-chairs for facilitating this session, Dr. Ishan Bakshi, Sam Professor Demeka, thank you so much. All our leaders, I could see some of our governing board members connected, even the executives from other chapters are connected. I want to say thank you to everyone, all the countries that are connected. I know it's very difficult. It's late in some countries, past midnight. Some is 1 a.m., 2 a.m. I want to say thank you so, so much. Thanks for taking the time out of no time to connect. Thank you to all the speakers. Dr. Soni was actually on a flight. He landed a few minutes back and he's still connected. I was thinking he wasn't going to make it, and he's still connected. We were meant to be having 3 speakers. Unfortunately, the third speaker is admitted, and we are sending prayers, and hopefully she recovers soon. So I want to say thank you to everyone once again. Hopefully, maybe we can have one more session before the end of the year in relation to another field, or it could be the last one, who knows, but we could have one more before the end of the year. So thank you so much. I could see some people asking for copies of presentations. The speakers can send them to us and we will pass them across when we send the certificate. So thank you so much for connecting.
Very
thank
happy.
you, everyone.
No problems.
You want to say something?
I'm very happy to share the presentation.
Okay. Yeah, you can send it to us afterwards. Thank you so much. I want to say, depending on your time zone, good morning, good afternoon, good evening, everyone, and have a wonderful night rest. And I'll see you again. Thank you.
Thank you.
Bye. Mind yourselves. Bye. Bye.
Bye. Bye.
Bye.